Hello and welcome to yet another exciting episode of podcast brought to you by ICCM. This is your host, Dr. Monalisa. I will be co-hosting this session with my colleague, Dr. Jaicob Varghese. And we have an immense pleasure in introducing our speaker for today, who is world's foremost expert in hepatology and critical care. Yes, you guessed it right. It's Professor Julia Wendon. She's a pioneer in management of acute liver failure and critical care hepatology. With decades of experience, her groundbreaking work has transformed how we are understanding and treating liver-related illnesses in intensive care setting. Currently, she serves as a consultant critical care in King's College London, where she continues to lead the charge in research, patient care, and education. The combination of her research, teamwork, publishing, and lecturing has resulted in improved survival of liver failure patients not only in UK but worldwide. She has published more than 270 peer-reviewed journals on acute liver failure and organ support. It's an absolute honor to have you, ma'am. Welcome to the podcast.
So thank you very much indeed for that very kind introduction. And it's great to be here with you.
Thank you, ma'am. Thank you for joining us. So, ma'am, I'll go with my first question. In the context of acute liver failure, are oliguria and elevated creatinine levels always indicated of hepatorenal syndrome?
Okay, so that's a really interesting question, because I think the first thing I'd say is almost never. Because in acute liver failure, this isn't hepatorenal failure, it's acute kidney injury. So hepatorenal failure is in the context of established portal hypertension. That is rare to non-existent in acute liver failure. So oliguria and creatinine changes are very much indicative of an acute kidney injury in the context of acute liver failure. And of course, recognizing that urea is a useless measure in that regard. Creatinine in acute liver failure, more useful than in chronic liver disease, where the loss of muscle mass and liver function significantly impact on creatine production and hence the level of creatinine. But we also see that to a certain extent in acute liver failure because of the acute loss of liver function.
Thank you so much, Dr. Julia.
Professor Wendon, you have been practicing liver intensive care for many decades. So fluid resuscitation, a challenging and a controversial topic in each and every aspect of critical care. So our next question is regarding what is your methods of assessing and volume status in a patient who is admitted with acute liver failure or acute and chronic liver failure with a sepsis or septic shock or with hepatorenal syndrome?
Yeah, it's a really difficult one, isn't it? And at least you've just asked me about the assessment of them, not which fluid I'd use. So I think first of all is clinical acumen. We need to look at the jugular venous pressure. We do not necessarily need to look at the amount of peripheral edema. It is the central blood volume that we are particularly interested in. In chronic liver disease, one recognizes that a large percentage of the vascular volume sits in the splanchnic bed, and the majority will be relatively underfilled, but a proportion will have volume overload and indeed pressure overload as part of portopulmonary syndrome, which may be precapillary or postcapillary. So for me, it's clinical acumen. I think increasingly we utilize echocardiography and ultrasound at the bedside. You need a skill base in order to be able to do that, however. I think if you're going to use invasive monitoring, then you pick your equipment of choice that you are used to using. And that might be a PICO, it might be invasive cardiac monitoring in the form of a PA catheter, but you need to understand that a monitor never changed anything. It's what you do with the data that's important. And just relative to think, don't overload these patients. I think increasingly we recognize that excess fluid is detrimental, too little fluid is detrimental. It's like cooking. You've just got to get it right, and there are many ways of getting to that end point.
Thank you for completing the answer with an example in the daily practice.
So now we'll talk about the role of plasma exchange in acute liver failure. So what do you think is the current indication or role of plasma exchange in the management of acute liver failure and acute on chronic liver failure?
Okay, so let's first of all start with what do we mean by plasma exchange. We utilize in my practice plasma exchange using a filter rather than centrifugal. And then you've got to determine dose, usually 1.5 times plasma volume, as opposed to high volume. So that's what our standard is. If we look at it in the context of acute liver failure, there is the big multi-center study of Finn Larson and colleagues. I was involved in that, so accept that I'm going to be biased. That was 100% fresh frozen plasma replacement, and it clearly showed a benefit in terms of non-transplanted survival, with clear signals also for that cohort who fulfilled transplant criteria that weren't listed, and for the cohort that fulfilled transplant criteria and were removed from the list, largely because they were deemed too unwell. So there is a clear benefit in that study, and it's a good number of patients, just shy of 200. Why does it work? Well, it might remove toxins, and we certainly showed that it removed some pro-inflammatory mediators. It removed DAMPs also. But one should also remember the data that shows that giving fresh frozen plasma, and this is old data, improves your opsonization and hence your engulfing of bacteria and improves your immune function in that regard. And that was work, I think, by Joe Canalisi back in the 80s that showed that. So I think there is a good rationale. There is nice data coming now out of the Indian subcontinent, some case series, but also a randomized controlled trial, again showing that significant survival benefit. But I'm going to put a big but in here. Those studies were largely undertaken with patients with hyperacute and acute liver failure. By the time you've got subacute liver failure, where you've got a nodular, shrinking liver with a bit of splenomegaly and a high bilirubin, the vast majority of that cohort of patients will need a transplant. So let's just be considerate about looking at what went into the studies and developing then our clinical practice. There was then a study that's just been reported. It's a real-world study in the UK looking at everyone with plasma exchanged with acute liver failure. And that showed no benefit. So you have to question, why was that? It was case-matched, it was historical, it was retrospective case series, all problems. There probably weren't enough numbers in it either. But also the timing wasn't consistent. And what we do know in terms of immunology is if you do it too late, you might make things worse. So what's my message out of this? Do it when people are getting established organ failure, on a bit of norepinephrine, encephalopathic, then you see benefit. You've got to have determined whether you're going to transplant or not, because you're going to muck up all your measures. And we've got to get cleverer at measuring immunology at the bedside. Acute on chronic, certainly for alcoholic hepatitis, I think there might similarly be a rationale. For the other acute on chronics, again, there are case series and studies coming out of India suggesting benefit, but let's get some big randomized control studies before we all jump in and do something that might not always be beneficial. Acute on chronic is quite a big heterogeneous group. We've got to make sure we get the timing right and the choice right, even though I'm an enthusiast for this modality of treatment.
Thank you so much for making it simple and explaining each and every aspects of plasma exchange in two different conditions where intensive is faced in the ICU. Professor Wendon, we'll go on to the next question. This is regarding the varied etiologies of acute liver failure. Cut across countries, we have toxins and drugs causing acute liver failure. We have infections causing acute liver failure. So is there any difference in the treatment approach in these two clinical scenarios?
So I would argue that by and large not. Good intensive care, good management of organ dysfunction is what this is all about. But the etiology is important, particularly in regard to prognostication. And I would consider these patients very much in terms of, is there a treatable component? of the, let's call it the precipitant. So is there an antiviral I should be using? Is there an antimicrobial, perhaps for leptospirosis? Should I be using Sibylline for mushroom poisoning? In terms of paracetamol and acetylcysteine, but I think the evidence base across various etiologies is good, so I broaden that. But mainly I would aim to look at it in terms of hyperacute, acute, and subacute. In the Indian subcontinent, you have a particular issue with rodenticide, a fascinating disease program in terms of how it affects a multi-system disease and how you might intervene at different time points to try and mitigate the course of that disease and when or when not transplant is important. So absolutely there are differences. Good basic intensive care holds for everyone, and the prognostication and the decision-making retransplantation needs to be personalised to clinical scenario and individual precipitant.
Thank you so much for answering that question. We will go to the next question. This is regarding the centers which is using devices or methods for a bridge to transplant. We have moved from artificial liver support system. The mask is something which has been commonly used. So could you elaborate on these kind of modalities and their advantages and disadvantages when compared to plasma exchange?
Okay, so we've never done a head-to-head. So compared to plasma exchange, I can't say. So it would be an interesting study to do. We have a plethora of various liver support systems available to us. By and large, they have shown limited or poor benefit. So the ELAD system has not really shown benefit. There is one Chinese study which shows some benefit. It hasn't been replicated elsewhere. And the logistics of using hepatoblastoma cells on a filter is really complicated. So I think that's still research only. We then have the adsorbent systems, and I think we mainly look at Mars or Prometheus. They didn't show benefit in a randomized controlled trial of acute on chronic liver failure. You can cut the studies and say, did we do them at the wrong time? Did we do them too late? Did we do them too early? But we really can't say that there is an evidence base until we go forward and do those studies. We've got evidence that Mars certainly seems to improve encephalopathy, so you get resolution slightly faster. You've also got L-ornithine L-aspartate, which shows that. So you're going to have to choose whether you want to expose your patient to the risks of these systems rather than the, at the moment, putative benefits. There was an excellent randomized controlled trial, meta-analysis published in the Intensive Care Medicine Journal a few years ago, suggesting a signal towards benefit. They mixed acute liver failure and acute on chronic. And the two big studies that probably biased that was the plasma exchange in acute liver failure and someone by Quinn et al., which was also a plasma exchange and adsorption system, I think from China or Japan, I can't remember exactly. So one's got to look at that. And then another paper last year, which again showed benefit for plasma exchange, a signal for adsorbent systems such as Mars, but not a clear signal. DiaLive is now out and about, and we need to see what that does in some big randomized controlled trials. So at the moment, I would say we're still looking for opportunities. As we see our colleagues developing livers on a rig, you wonder about options in that regard. So I think there's a real excitement about what might be coming down the track, but I think we've got to really design clean, well-developed studies to really assess efficacy, rather than, I'm a doctor, I want a machine that goes ping, I want my relatives and my patients to think I'm doing everything. Let's never forget that things have side effects.
Yeah. Thank you for that crisp answer. Thank you.
Dr. Julia, we'll end this podcast with a very challenging topic, acute liver failure in pregnancy. So what are the unique challenges and considerations we need to keep in mind while diagnosing and managing an acute liver failure in pregnant patients? And what effect does it have or implication does it have on maternal and fetal health outcomes?
Gosh, that is a good question to end with, isn't it?
Yeah.
So first of all, I'd say let's separate them into pregnancy-related acute liver failure and perhaps viral infections in acute liver failure, or toxins, because that's perhaps the best way of looking at it. So occasionally some people take overdoses or other drugs when pregnant, and we should treat those patients just as we treat any other acute liver failure. One's focus, as always, or certainly in Europe, UK practice, would be the health of the mum. That's what you've got to focus on, is the health of the mother. So we treat mum. We've then got the liver diseases associated with pregnancy. There are the rare occasions where you might have a prothrombotic condition and Budd-Chiari, and you need to deal with that as you normally would. You need to consider, if you're going to have to put a TIPS in, what that radiation risk is. And again, for me, mum is the primary objective here. And the evidence actually on irradiation and fetuses, separate conversation, but really quite interesting because a lot of it is historical data, not modern data on the amount of radiation. Then you've got the cohort that you see particularly in India, your acute liver failure related to hepatitis E, perhaps also in the African subcontinent, where it's a very different disease to that which we see in Europe and USA and Australia, very much a hyperacute disease. And you probably know a lot more about managing that than I do, in all honesty, but the evidence base in the literature would suggest you should treat these mums just like you would any other patient with acute liver failure and focus on that and the prognostic criteria. Now, for the pregnancy-related, cholestasis of pregnancy we'll put by the side. They're usually ambulatory, but then we've got preeclampsia, we've got adenomatous ruptures, we've got HELP, and we've got fatty liver of pregnancy. So with the eclamptics and the adenoma ruptures, they're really difficult. You need to manage that rupture with your surgical colleagues and your interventional radiologists. Again, focus on mum, delivery of fetus if the fetus is of an age that it can be delivered. For your HELP syndromes, some evidence base for steroids, thinking about that and following those criteria. And then for your fatty livers of pregnancy, again, if the fetus can be delivered because it's the suitable age, that's useful because their liver failure will improve over the next 48 hours, but you need to focus on that balance, and what you're looking for is mum. The fatty livers, we've also got to consider the high risk of pancreatitis and other organ failures, and managing them as both a pregnant mum and someone with acute liver failure. Sorry, that was a slightly splurgy answer, going across a breadth of areas.
No, absolutely not at all. I mean, you touched on every aspect of it, highlighting the importance of early detection, comprehensive set of tests which we need to send and do a differential diagnosis, and also multidisciplinary care. Thank you so much for highlighting this important topic. Thank you, Dr. Jyoti.